Thanks for staying.
It's quality, not quantity.
I guess everything's been said. Pretty much. I don't think so. You know, there's about 3 or 4 talks that have been kind of rolling around in my head all day, and I haven't been sure which one to give, so they come out discombobulated. But what? What's research done for you? Is the prevalence of alcohol dependence lower now than it was 10 or 15 or 20 years ago? No. Public health burden down? No. Is treatment outcome any different than it was 60 years ago? No. Are our providers anxiously looking at the newest publication of alcohol clinical and experimental research to see what new tools they can apply? No. Now, to be fair, this is a new field, and the brain is one heck of a complicated organ. It took decades of research and hundreds of billions of dollars before we actually started to see public health benefits for cardiovascular disease, for treatment of cardiovascular disease. What concerns me is that I think many people look to us to provide the rationale, well, first of all, proof that our disease is, quote, real. And secondly, which means, I think, physical. And secondly, that what we're already doing works just fine if only people would give us enough money to do it. An example is when we have these 21 million people who, quote, need treatment. That means that they meet diagnostic criteria for alcohol or drug use disorder. It doesn't take much in these surveys to meet that. Most of those people are not disabled, distressed, or causing anybody any problems. That's one of the things we forget. We're not dealing with a unitary disorder. And I want to talk about that a little bit. It's a much more complex reality. And one of the things, I gave a video cast conference a month or so, 6 weeks ago. And it's available on our website if you want to look at it. The title of it is Alcoholism Isn't What It Used to Be. And what I mean by that is that the new findings out of our epidemiological research in particular, but other research as well, is really showing us that what we thought we knew was wrong. A lot of what we thought we knew was wrong, or at best, significantly incomplete. And my concern, as much as I support, and I'll say a couple of words about my bona fides, as much as I support and appreciate your work and the importance of this nascent movement, I have concerns that if we don't grapple with what we actually know about this, we may end up being less effective than we otherwise could. And that's my concern. We need each other, I do believe. I think that there has been, it is, and it has to be a peculiar, it's actually true, I think, if you look throughout history, that before we had the scientific underpinnings for understanding the disease, and we had a truly effective treatment, the diseases were stigmatized, and there were a lot of questionable things done to both explain them. The term thin and rich. That was because because these people had tuberculosis, but nobody knew that. It was called consumption in those days, and it was a sign of status, in the upper class, that we were thin and rich, and kind of an aesthete. Susan Sontag wrote a wonderful book called Illness as Metaphor. She talks about cancer and the changes in cancer, understanding stigmatization. And even now, you know, although we think our disease is particularly stigmatized, what's the first thing you hear when you hear that somebody had a heart attack? Oh, he must not have taken care of himself. That's all those hamburgers, all those donuts he was eating. I told him he should exercise. In other words, it's his own fault. So part of it is, of course, we're terrified of things that we can't control. I'm just saying that I think that we're young. We're a young science, a young treatment industry, organizations, and recovery is you know, part and parcel of that. I told you to be disorganized. Okay, I just wanted to, so here are a couple of definitions to throw out to you to consider. A disease, illness, or a disorder is a condition characterized by failure of self-regulation of an organ or organ system, causing clinically significant impairment or distress, or an increased risk for development of same. So in our case, what we're talking about is failure of brain systems that modulate reward, affect, memory, and motivation. Okay, remission is disappearance of the signs and symptoms of a disease. Partial remission is where some but not all signs and symptoms are no longer present. And full remission is where all signs and symptoms of a disease are no longer present. Response, on the other hand, is a significant reduction in impairment or distress in the absence of full remission. That would be response to treatment. And non-response is no change or worsening of impairment or distress following treatment. Well-being is a measurable state characterized by dominance of positive over negative affect, effective coping, social support, and productive activity. There's actually a very interesting and growing body of evidence concerning what constitutes well-being. So here's my thesis, that recovery is a condition characterized by full remission and a state of well-being following an episode of illness. That is, remission is a necessary but not sufficient condition for recovery, which I think is consistent with what we've been talking about today. What's interesting, and I think should be the focus of further conversation, is that in some disorders, notably serious and persistent mental illness, recovery does not require remission. Recovery does not require remission. It's considered in some ways independent of symptoms and impairment, and it's living with. And in many other chronic illnesses too, for that matter, it's living with symptoms and impairment and living well. Dan Anderson, one of the founders of the Minnesota model in Hazelden, said that the secret to growing to longevity, the secret to longevity, living a long life, was to get a chronic illness and then take very good care of it. I think this is something we need to talk about, because one of the other concerns I have is that we could actually increase stigmatization for people who are unable to achieve recovery. Another, we heard earlier this morning about some of the things, the old style treatment that we all remember, many of us do. Here's something else, though, that I wanted to say was one of the first things I was told when I started working in this field. Treatment doesn't fail people, people fail treatment. And this is a major concern I have, because I think one of our enemies is idealism. One of our enemies is idealism, and it's easy for there to be an assumption somewhere back, unstated, that if a person is really motivated, they can find a way. Now, in terms of bona fides, in 1986, I started a clinic for medically ill alcoholics who were still drinking, people with cirrhosis and pancreatitis. People everybody else had given up on. They'd been through treatment, rehab a couple times. And we said, well, let's see what we can do. So we treated their liver disease or whatever that we did in primary care, and we addressed their drinking. And we said, okay, we're with you till whenever, till you don't need us anymore, until until you die if necessary. And I can tell you that staying with an alcohol-dependent person as they die over a period of 2 or 3 years of their alcohol dependence is a difficult and painful thing to do. But I've done that with dozens of people now. And so one of the things I would say is, why do we need science? Why do we need research? Because our outcomes aren't anywhere near good enough. That's why. One of the things when we came out, you may remember when the combined trial came out, it was a big study about medications versus a couple different medications and combinations, and a couple different psychotherapies and combinations. A complicated study. But one of the findings was that naltrexone, one of the medications, plus just medical management like you might do with a diabetic, had the best outcome of all. And it was better than state-of-the-art behavioral treatment. And that made people uncomfortable. That makes people uncomfortable. Now see, one of the things we don't like about research is it makes us uncomfortable. It tells us things we don't want to hear. And the thing about it, for example, one of the comments was, well, okay, sure, you can give somebody a medication and maybe they'll get abstinent, but that's not recovery. And I agree with that. However, as a practicing addiction psychiatrist, I can tell you most of the time, I'll take abstinence. I'd be glad to. I mean, most of my patients right now, are people who've been through rehab a dozen times. And the system is not well situated right now to deal with the chronicity of the illness in those who have the chronic illness. And let me just say a couple more things that'll make you uncomfortable, that are things that we know are true, that none of us wanted to hear. Residential treatment is no more effective than outpatient treatment. 4 sessions of behavioral therapy gives you the same result as 25. What else? A medication plus brief behavioral support is as good as state-of-the-art behavioral treatment. We don't want to hear that. We don't like that. In Project Match, 10 years after the receiving treatment and so forth, and it is true that about a third, if you look at the first year, about a third remain in full sustained remission throughout the entire year, and at any point in that year, 50% are in recovery. And I think the outcomes are good compared to what most people think. But after 10 years, in one site where they were followed out 10 years, fewer than 10% never had a recurrence of illness. 90%, more than 90% had recurrence. So we have to be a little careful, again, about being idealistic about what we mean when we say long-term recovery. It doesn't mean that there won't be recurrence. And how do we deal with people who cannot recover? We have to be careful that we don't abandon them. Now another thing I'll say is, okay, so we've been talking, there's been a lot of talk about money today. Where should the money flow from and to? And I think one of the key questions for us all is, what's the role of the healthcare system? And what's the role of other systems? And Wesley talked about this to some degree, saying, well, he was talking about it as the government, because for drug abuse treatment, it's mostly public funding. Alcohol's a little different, and I don't think it's about government. I think it's about healthcare, which provides, I'll give you a definition, versus what the community does in terms of providing what Rudy Moose calls a recovery context. I think that's an incredibly important concept, a recovery context. So here's some questions. Recovery from what? Are remission and recovery different, and if so, how? I've told you how I think they are different. How do we measure them? Well, measuring remission is pretty easy, although there are still lots of issues there, but that's relatively easy. Measuring recovery, not so easy. And then finally, what is treatment? So let me just, what are the goals of healthcare services? In other words, what should we be spending our healthcare dollars on? What's justified versus what is the community's larger responsibility? What's the best way to achieve these goals? And here again, what are the other institutions and activities? What is their responsibility or role vis-a-vis recovery? So first of all, recovery from what? Here he says, sorry, no water, we're just a support group. So, do we mean alcoholism, a primary, progressive, incurable disease characterized by craving and loss of control over drinking, which if not arrested leads inevitably to physical, psychological, social, and spiritual ruin and ultimately death? Is that what we mean recovery from? Or do we mean alcohol dependence, a disorder characterized by impaired control over drinking, spending increased amounts of time on it, used despite physical or psychological consequences, caused or exacerbated by tolerance and withdrawal, that is, meeting 3 out of 7 DSM-4 criteria within a 1-year period? Because those aren't the same, those two things. Or do we mean chronic excessive alcohol use, which increases the risk for acute problems, such as physically hazardous use and trauma, and for end organ damage of 2 organs in particular, the liver, which is fibrosis and cirrhosis, and the brain, which is dysregulation of the systems regulating pleasure, reward, motivation, and incentive salience. That is, addiction is a result of excessive alcohol use, not the other way around. Then it becomes a self-perpetuating cycle. So addiction is an end organ damage from excessive drinking. Interesting. Okay. Changes in diagnosis. You probably all know what a standard drink is. 14 grams in the U.S., 14 grams of absolute ethanol, 12 ounces of beer, 5 ounces of wine, 1.5 ounce shot of age-approved booze. And our heavy drinking recommended maximum limits are no more than 4 drinks in a day for men and no more than 3 drinks in a day for women. So when I talk about a heavy drinking day, I'm talking about 5 or more drinks in a day for men or 4 or more drinks in a day for a woman. Regular heavy drinking we consider to be monthly or greater, exceeding those limits. And an alcohol use disorder is heavy drinking plus symptoms and or dysfunction. Now this is actually how it looks in the U.S. But in a given year, about 70% of the adult population, 18 plus, do not ever drink in excess of those guidelines. They either abstain or they drink less than that. So that means about 30% drink in excess of that in a year. Now 2/3 of that group drink in excess of that but have no current symptoms, no diagnosis for any kind of disorder. And we currently call that at-risk drinking. We don't call that a disorder. So this is risky drinking. And then about 1/3 of it has symptoms associated with it. Among that 10% that have symptoms, about half have some kind of sequelae that are typically associated with episodic heavy drinking, or they have some like liver disease and they continue to drink. And we can call that harmful use. You might call it abuse, although it doesn't really fit well. There are a lot of problems with DSM-4. And then about 4% have dependence in a given year, about 3% having dependence, and then only about 1% having chronic dependence. So there's 2 models we're working with right now. There's episodic heavy drinking, which really leads to social dysfunction, acute trauma, and other acute illnesses. And regular heavy drinking, which leads to brain disease, which is addiction, liver disease, and other adverse health outcomes. Now, importantly, not everybody gets these. Just like not everybody with high cholesterol gets a heart attack, not every smoker gets lung cancer. Only about 40% of smokers get lung cancer. So, or COPD. So it increases the risk, but it's not inevitable. As a matter of fact, this slide shows alcohol disorders in heavy drinkers. This is the number of days per year. So out here at the end is daily heavy drinking, okay? And you can see in this particular study, they kept abuse separate. So this is a dependence without abuse, abuse only, and dependence with abuse. Abuse only peaks at once a week. That's what I'm saying. I think abuse is typically episodic drinking. What's important here, though, is that if you add all of these up among daily heavy drinkers, 57% meet criteria for abuse or dependence, which means that 43% of daily heavy drinkers do not meet criteria for any alcohol disorder. Now, what is an alcohol disorder? Well, we're talking about dependence. The original paper in 1976 by Edwards and Gross, narrowing of the drinking repertoire, salience of drinking-seeking behavior, tolerance, withdrawal, relief or avoidance of withdrawal by further drinking, subjective awareness of a compulsion, and reinstatement after abstinence. That got basically translated into DSM-4 and ICD-10, tolerance, withdrawal, trouble quitting or controlling, using longer or larger amounts than intended, neglecting activities, spending a lot of time in use despite physical or psychological problems. By the way, use despite does not mean social problems. It means like hangover or nausea. This slide shows that the frequency of heavy drinking is associated with the number of symptoms of alcohol use disorder. It's also true that abuse and dependence don't act the way we thought they would or should. That is, some abuse symptoms occur only in very severe disorder. The symptoms that occur first are 2 dependence symptoms, and then 1 abuse symptom, which is hazardous use. 90% of people who have abuse do it because they drink and drive. That's 90% of what we call alcohol abuse. So the more frequent you drink heavily, the more likely you are to have an alcohol use disorder. But you could also, this is associational. You could also say, you know, the more symptoms of alcohol use disorder you have, the more likely you are to drink heavily. Okay? This is an association. So in my mind, increasingly where I'm going is that so what we call at risk group is like people with high blood pressure before they have a stroke. People with high cholesterol before they have a heart attack. Now, why do we call high blood pressure a disease? Is it because people feel bad? No. It's because it's a risk factor for downstream consequences. It turns out that the genetics of how much you drink are actually stronger than whether you get alcohol dependence. So increasingly, I'm beginning to think that the disorder is heavy drinking. Right now, the way we diagnose alcohol dependence is, if we diagnose high blood pressure the same way, we'd have to wait until you had a heart attack or a stroke. And then we'd say, okay, now you've got high blood pressure and I can treat you for it. That's what we do right now with alcohol dependence. We wait for the complication. So, when we talk about early intervention, I mean, I think we have to go over here, where we have regular heavy drinking as being actually the disorder. Okay. Now, who drinks heavily? Well, young people. I'm sure that's a shock to you. It certainly was to me, because I certainly didn't drink like that when I was younger. I mean, it peaks out, right at 20, 21. Blue is males, this is females. Males drink more. And it, goes down fairly rapidly. This is 30 here. It really goes, really has a sharp peak. The alcohol dependence has an average age of onset of 21 years. This is the prevalence. The prevalence actually peaks before the age of drinking legally. Here at it's about 13, a little under 12.5% here among 18 to 20-year-olds. And it very rapidly decreases. Now, a lot of us think that this group doesn't have the same disorder that this group does. That's part of what research is about. Now, the average age of first treatment is more like 29 to 31, 10 years later. And the average person in our trials is 40. We know a great deal about 40-year-old white male alcoholics in treatment, and we know almost nothing about anybody else. Not everybody has the same course. There's this early onset and recovery, a common one, about a third. Typical treatment case peaks out about here, and then maybe, in this case, a good, this is severity here, I'm going up over here. Treatment case goes to treatment, becomes abstinent, that works. But here's chronic and severe. Here's chronic but moderate. Very interesting group, very treatment resistant. This group, chronic and moderate. George Valiant has followed them now. They tend to stay just this way into their 80s. And this disorder is not typically progressive, by the way. In fact, there are multiple subtypes, new subtype analysis. Very quickly, a third have mild self-limiting heavy drinking in youth. About a third. They meet on average about 4 criteria, not very many. Now remember, all you have to do to meet criteria is to say that more than once you've set a limit and gone over it, you've had a persistent desire to quit or cut down, and that you've kept on using despite hangovers. Now, by bingo, you've got alcohol dependence. Does that say anything about social dysfunction? No. That's what, so, and to some degree, this is about diagnosis. So the thing here is that almost none of these folks seek any kind of help. Now, seeking help, that includes going to your minister, talking to your doctor, to a therapist. None of these folks go to treatment, okay? And almost all of them recover. About 40% have midlife onset, moderate symptoms. They don't drink as much. Very few seek help. Almost none go to treatment programs. Virtually none. And then a third have what we typically think of as alcoholism. Early onset, average age of onset, 16 years old. And more symptoms, very, very heavy drinkers, more likely to have family history, antisocial behavior. And they're the ones you can see, especially this group here, who go to treatment. These are the group that we think of when we talk about alcoholism. These are the ones in AA and in treatment programs. That's what we think is alcoholism. But I'm saying that if you look at the population, it's a much bigger picture than that. So if we're only focused on this group, we're really going to be missing the boat. There was a lower prevalence of cancer in people with TB. So the scientists who studied that led to a recommendation to infect cancer patients with TB. This is true. But in fact, what happened was that TB was simply more common in the cancer cases that went to autopsy than the ones who did not. So you can see the kind of problems you can run into when you generalize from treatment populations. Okay, here's another zinger. Almost 3/4 of people who have an episode of alcohol dependence in their lifetime have a single episode lasting, on average, 3 years. They then remit and don't relapse. So only about a quarter have more than one episode. If you have more than one episode, you have an average of 5 of decreasing length. So it appears like there's 2 forms of this disorder. Maybe 3. There's probably a mild self-limiting form, in between the ages of 18 and 25. There is a moderate form that typically has a single episode. And then there's more severe and relapsing disorder. So why is this important? This is important because there's an interaction between perceived need for treatment and the perception of what the treatment is. Those are not independent. So people who are functional, they're not really seriously ill, but they are suffering, they are concerned, but they're not concerned enough to go, to enter a treatment program, accept a diagnosis that will stigmatize you the rest of your life. You'll never get life insurance, you'll never get a security clearance. Nobody will ever see you the same way again. And not only that, but I frankly think most people do not relish the idea of group counseling. I don't think that's a particularly attractive idea for most Americans. They don't, most Americans really don't like counseling at all, even one-to-one, frankly. You see that with depression. In a depression trial, they gave people a choice of free. State-of-the-art cognitive behavioral therapy is one of the choices. Only 10% of this 1,200 people in the study would even agree to be possibly randomized to cognitive behavioral therapy. They wanted medication. So we have to be thinking about patient preference here and appropriateness. We have one model of treatment. We need more than that. Okay, what about natural recovery? I'm going to pay for this tomorrow in yoga class. Okay, most change occurs naturally. So, again, only 13% of people with dependence in this country, lifetime, ever actually go to a specialty treatment program. Because the need for treatment is just having the disorder. So, I don't know how many of you have had a headache in the past month, but how many of you went to a doctor for the headache? So if you just say, well, anybody with a headache has a need for treatment, and you didn't perceive the need for treatment, you can kind of get what I'm talking about. This is just another study showing different trajectories for people who recover naturally versus with treatment. Treatment naive are in the red here. These are all just drinking trajectories, and then in the blue are the people who ended up in treatment. So, I mean, these are very different folks. Another thing, after 20 years, people with dependence, 20 years later, fewer than 10% are still dependent. 20% have partial remission. A third are abstaining. And guess what? 40% are non-problem drinkers. Okay, so the implications then is that there's heterogeneity. Most heavy drinkers don't have addiction. Most alcohol dependence is not recurrent. We don't understand the mechanisms of change in drinking behavior. Most change does not include either professional treatment or mutual helpers. And the current treatment programs are not appropriate for most people who drink too much, and they are, I think, neither attractive nor accessible for most people. So most people probably just don't like what we offer. So we need to somehow find ways to make information and services accessible, affordable, and attractive. Now, what is treatment? He says, I will life coach for Scotch. On the other hand, you've got to give him credit for honesty. Okay. So, is this treatment? Treatment being a highly specific, magical, transformative process that can only occur with my help and in my program? Is that what treatment is? I call that treatment with a capital T. You know, oh. Or in treatment, small t, a set of professional services provided for a fee, which are designed to assist individuals with a specific disorder or risk of a disorder. I think that's what treatment is. Let me give you an example of this. This was in this clinic for the medically alcoholics. We'd be working with somebody for 2 years. Okay, and it would be off and on, sometimes more intensive, sometimes less intensive, a lot of patient work, for 2 years, and they might not be really recovered yet. And inevitably, somebody said, well, he needs to go to treatment. I said, well, what do you think we've been doing? Okay. I know that time is up, but I just wanted to leave you with a proposal for a continuum of care that addresses the heterogeneity of the disorder. Okay? So for risk drinking and mild dependence, most people will respond to facilitated self-change and brief motivational counseling. We can make that available in a lot of ways. Now this is about recovery content. This is the community stuff here. And we can prevent a lot of problems just by getting people to count how many drinks they're having. The next step is I think most people in the future for alcohol dependence will be getting treatment in primary care. This is going to be, in 10 years, treatment for alcohol dependence is going to look like treatment for depression now. In the last 2 months, we've had 4 visits from big pharma companies who are developing new compounds to treat alcohol dependence. There's going to be a revolution in this in the next 10 years. What about the people who can't recover from that? Well, we need an addiction specialty sector, but we need a real specialty sector. We need to beef it up. We call ourselves specialists right now, but we aren't. As much as, we're not like specialists like cardiologists or specialists. So what we need is, we need to be fully integrated with medical and psychiatric care systems. These are all people with major comorbidities. We have to be able to manage those, and disease management for chronic relapsing disorders that they get treatment as long as they need it, or intermittently. Now, community recovery support, I think, is peer-oriented, primarily volunteer organization would provide a recovery context for individuals seeking support to initiate or sustain recovery from the disorder. I think there needs to be a partnership then between treatment and the community recovery support. So as a result of this context, I've added to this. This has been a work in progress now for a couple of years, with coordination with community recovery support organizations now is part of my, so the target group, I think, for this that we've all been talking about today is this chronic relapsing severe group, which is about 10% of people who develop alcohol dependence. I'm just saying, if we want to have a public health impact, we can't forget about the other 90%. Let's see. I'll just stop.